Well, this is amazing, you wonderful people, as I have been referring all the time. It has been 7 days of rigorous academic sessions, morning to evening, but not even for a single second we felt tired or we felt exhausted. It is your energy that is resonating at TAMC Medicos. It's been wonderful, wonderful, wonderful 7 days with us here, and I hope that you are equally benefited with things and inputs of our valuable faculty. You see, somebody has said, the ignorant at these times are not those who can't read or write, but those who cannot learn, unlearn the untrue, and relearn. So let's carry on the learning process here, and let's start the session on surgery urology, which will be taken by Dr. Sujoy DVT, and a brief introduction I present to you. Dr. Sujoy DVT has done his MBBS from UCMS New Delhi. He's done his MS General Surgery from UCMS Delhi. He has done DNB Pediatric Surgery from CNBC, affiliated to Maulana Azad Medical College. He has got a vast experience of 12 years from pediatric surgery and 21 years post MBBS. It's a wonderful and a very, very, very learned and meticulous speaker and a meticulous surgeon who he thinks that teaching at TAMC Medicos makes him a better clinician, gives him a lot of satisfaction, and as a teacher he remains young at heart. And last but not the least, he feels promoting surgical branches amongst young budding medical graduates gives him a lot of pleasure and satisfaction. Without much further ado, I switch over to our next session, which is surgery urology, that will be taken by Dr. Sujoy DVT. Over to you, sir.
Right, can hear? Good evening. Right, so we are going to start urology without much of bakwas. We start with urology straight away. As many of you have been attending my classes, today's revision is also going to be Bailey based images, and then we go and revise urology a bit. I think we should be able to complete in an hour, so please be with me. Many of you are my students. If some of you are not my student, you are meeting for the first time, please do let me know. I'll wait for some time for you to finish the notes. Everybody can hear me? I see some of you have said no audio, so please let me know you can hear or not. So this is the first question: what is this image and what are its uses? So what is this image? What is the so what is the image which you see? You can see it in your DVT books. What image is this? Right, so first times, please, I'll be slow so that you can complete your notes. All these images are inspired by Bailey. Bailey is the book which I trust, and I think this is the book from where the images are going to be asked. So the question is, many of you are quite intelligent. You know this is a urology lecture. तो ये तो cystoscope और ureteroscope में से कोई एक होगा. But today we need to know how to ensure that this is not an upper GI endoscope and this is not an ERCP scope, right? So let us quickly see the ways how we can make a mistake. So somebody can give this, how to identify this is a ureteroscope, cystoscope, or a GI scope. So let us quickly see GI scopes, right? So this is a GI scope. Please see GI scopes has two knobs. A GI scope can move in for two axes, like this also and like this also, two axes perpendicular to each other. But ureteroscopes and cystoscopes can have moved in only one axis. This one is ERCP, and you should be able to identify it because ERCP has side cameras. You can see ERCPs has side cameras, right? So if you see, ERCP has a side camera, side viewing, because you have to put the stent into the ampulla of Vater. Very important. And please do remember that ureteroscope and cystoscope cannot be differentiated based on seeing. It can be a ureteroscope also, it can be a cystoscope also. It is all different is the length. Ureteroscopes are longer and cystoscopes are smaller. Please do remember, I have shown you two arrows. This is the arrow through which you start irrigation fluid. In a cystoscope, you need to have irrigation fluid. And this is the port in a cystoscope from where you will insert forceps, also in short known as the working channel. So cystoscopes have two channels. From one, you can have infusion of some fluid, and from the other channel you can insert a forceps, you can insert something which you can hold the stone, Dormia basket, something to hold the stone. Another difference between a GI scope and a cystoscope is in GI scopes you need suction. There will be a port for suction. Please see here. This is for suction. In cystoscopes there will be no suction. So I hope you will be able to identify cystoscope versus GI scopes. Right? Please understand, I have told you the difference. Please note, this is a cystoscope also. It may be possible, it may be a ureteroscope also. It all depends upon the length. Nobody should be able to ask you this question that whether it's a cystoscope or a ureteroscope. Second question we go into. Yes. So ureteroscopes will be longer. Second question. Question is, what is this? The red arrow. This is a view of a cystoscope. So three questions attached to this. Identify the red arrow. Important points about the structure, and what are the other two arrows which are showing in a black and a blue. So we have done urology, I have shown in my class many scopies. So this is tricky, and if somebody of you are wondering from where this image has come, this is again from Bailey. So excellent. So very, very good. This is the structure which is the verumontanum. Excellent. Clap for all of you yourselves who have answered this as verumontanum. This is verumontanum, right? And verumontanum in Latin means mountain. So you can see this is a ridge. It's a ridge, is a mountain-like thing. Now verumontanum points which you should know. Before that, just see an animation for all those first comers. This is a TURP surgery, cystoscope animation. This is the verumontanum, and you can see both the lobes of the prostate which are coming to the center and causing an obstruction. Please have a look at this. This is the left ureteric opening. This is a trabeculated bladder. I'm going to show you another one. And please note that how the bladder is not smooth walled. It is all very rough. Here comes the instrument which is known as the resectoscope. I have shown it in the class, resectoscope. Resectoscope is the instrument which uses electric current through this tungsten wire, which converts into heat, and you cut chips of the prostate. Please do remember the fluid of choice is 1.5%. You know the answer, which is the fluid of choice. Someone can put in the chat box and you can see how very nicely chips of prostate are being cut. So any one of you who are having this in your mind, whether urethra is injured or not. Yes, urethra is injured in the first chip only. Urethral mucosa is resected out. And see, the passage has been made clear. There is going to be bleeding. So if anybody has sees this video before your March exam, you know one of the answers will be bleeding. And the irrigation fluid is 1.5%. Very nice. Many of you have said glycine. So glycine is the irrigation fluid. In the past, electric current was used. So many of the surgeons were afraid of conduction of electric current, and they were using distilled water, 5% dextrose, and that led to TUR syndrome. Everyone knows. I assume this is a revision. Even for the ones who we have not met, it should be something which you have already done. So in a TUR syndrome, the distilled water is going to go through these vessels into the circulation, leading to dilutional hyponatremia. So therefore we choose a fluid which is 1.5% glycine, which is neither going to be absorbed nor is going to conduct electric current. Right? So don't mess up. Verumontanum. All my students already know the verumontanum, 5 points to write. For those who have not been attended my class before, please update that verumontanum is the embryological remnant of the Mullerian duct in males. Number 2, very important, the ejaculatory duct opens at the verumontanum. Yep, correct. Number 3, which is very important, the external sphincters are present around it. Number 4, please remember that since the external sphincters are present around it, so the TURP surgery which you just saw has to be done proximal to the verumontanum. You should never cross the verumontanum. If this is the bladder neck and if this is the verumontanum, so the dissection of TURP will be done here proximal to the verumontanum. Excellent. And please remember, posterior urethral valves, short form is PUV, is located distal to the verumontanum. These are the 5 points for verumontanum. In Latin, verumontanum means mountain. I think we have given enough time for even the newcomers, new people to know about verumontanum. Verumontanum is seen in male urethras, posterior urethra. Right? And please let us revise prostate once again. There is a very famous classification by a very famous anatomist. His name was McNeil, and he classified prostate into 3 zones. Peripheral zone. Peripheral zone is the source of carcinoma of the prostate. Please do remember that peripheral zone is responsible for the pseudocapsule of the prostate. It goes to the periphery and forms the pseudocapsule. Right? So very nice. Somebody has asked, very good. So somebody has asked, what are the black and the blue? So black and the blue are the lateral lobes of the prostate. These are the lateral lobes of the prostate. Very nice, you asked black and blue. These are the lateral lobes of the prostate. So we go here, the 3 zones. The first zone is the peripheral zone, which is the source of the cancer in prostate, and it forms the pseudocapsule. Please do remember the central zone. Central zone forms the median lobe, and the median lobe is responsible for the bladder outlet obstruction. And the third one is the transitional zone, which is responsible for the BPH. And very important thing, since in TURP we do not remove the peripheral zone, so after TURP also a person can develop CA prostate. So very, very important. Tomorrow you have a question that patient has undergone TURP 5 years back. Today can he have CA prostate? Yes, he can have CA prostate, because in a TURP you don't take out the whole of the prostate. Peripheral zone is still there. My newcomers and my students who are already revision, I hope this point is very clear. So it is going as per the images which are coming in your book, right? So we are doing the second image in which we have seen a prostate, and this is what is the revision for the prostate, right? Another very important message which I wanted to make clear for all of you newcomers and oldcomers who believes about PSA, prostate specific antigen. Before you go for your March exam, I want all of you to convey the message of Bailey and Love Uncle that PSA is not a mandatory investigation for workup of a benign prostatic hypertrophy, right? So the 5th point of verumontanum was that the posterior urethral valves are located distal to the verumontanum. BOO stands for bladder outlet obstruction, right? The mandatory investigations for TURP, please do remember, is urine routine, microscopy and culture, a serum creatinine to look for the renal functions, a study of the flow rate, and an ultrasound for post void residue. Right? So Sandeep has asked what the uses of cystoscopy. Cystoscopy has diagnostic uses. Cystoscopy has therapeutic uses. I have already shown multiple videos. You will come because in cystoscopy is the only device which can go into the bladder and see. It can be used for taking out bladder stones. It can be used for doing small biopsies. So these are the uses of the cystoscopes. I hope everyone has written this. Adequate time. Right? You also must know what is the investigation of choice for BPH. If somebody asks what is the investigation of choice for BPH, right? For BPH, what is the investigation of choice? Is it going to be a transabdominal ultrasound or is it going to be a truss? Which is the investigation of choice? Right? So these are the additional points which you have to write in your notes. This I have not mentioned. Unless you write some things on your own, it will not register. Before March, you have to write something so that, and those who already have the notes, you just have to tick in your notes that you register them. So transabdominal ultrasound or truss. So please do remember before the day that the investigation of choice for BPH is transabdominal ultrasound and not truss. Truss is used for only two reasons. One is to obtain biopsy, and number two use of truss is to do staging for carcinoma. These are the only two uses of truss. So like Dr. Meenakshi Jha and Sarthak and many more whose messages I have missed. So please you have to correct yourself before your March exam. You do not use truss for diagnosis of a BPH, which is so common. Truss is very sadistic. Truss is inserting a very big rod into the rectum and trying to diagnose something. That is height of sadism, right? PSA stands for prostate specific antigen, right? Again, image from Bailey. Quickly tell me that if you are shown this image and there are these yellow marks shown in these ridges, this is not a smooth outlined inside of the bladder. These are ridges which are seen. What is the arrow denoting? What symptoms arise and why do the symptoms arise? What do you mean by trabeculations? These are trabeculations. Even for prostatitis, transabdominal ultrasound can diagnose, but sometimes prostatitis which you are not able to differentiate from cancer, you need truss for confirmation. Right? So trabeculations. So very, very important. For again, the students who have already done it, you already know this we have done to the extent that you can remember and say even in your sleep. For the ones who are newcomers, let us quickly do that. Suppose the outlet of the bladder has an obstruction. Suppose here there is an obstruction. There is a bladder outlet obstruction, right? Then what will happen? The patient will experience flow problems, stream problems, retention problems. These symptoms are known as the obstructive symptoms. Again, my request for all those who are new, don't use much of your head. Just write this flowchart down so that you remember. Obstructive symptoms, if it is your own you imagine some of your cousin grandfathers or your own grandfathers who are having prostate problems. If you operate them early, right when the obstructive symptom occurs, they are going to be complete reversal of the symptom. The patient is going to be extremely happy. But if you are not going for treatment, if you try Desi treatment, Ayurvedic treatment, homeopathic treatment, if you are shy to go to the hospital, then the bladder muscles are going to compensate. They are not going to sit idle because their job is to evacuate the whole urine out. So if obstructive symptoms are not removed, the detrusor muscles are going to hypertrophy and these will lead to trabeculations. The image which you saw was trabeculations, hypertrophy of the detrusor muscles. And when detrusor muscles, which are involuntary muscles of the bladder, when they hypertrophy, they are going to have their own sweet contractions. They are not going to be under the normal nervous control. So they are going to have contractions even while filling. And these symptoms, because of detrusor hypertrophy, are going to be called as the irritative symptoms. So if you have an old man in your home who means a lot to you, you must push him for a treatment for bladder outlet obstruction right at the obstructive phase. If he goes into the irritative symptoms, then it is very difficult to reverse, because if you stop going to the gym, then your biceps and triceps are not going to go back to normal the next day. They are going to take time or never come back to their normal size. This and this both are known as LUTS. Many of you have already said. LUTS stands for lower urinary tract symptoms. So bladder outlet obstruction gives rise to LUTS, and LUTS is first early is obstructive. If obstructive not treated, then they are going to irritative symptoms, right? So please tell me that you have written this down. The newcomers have written this down. Right? So Shabia, speed, I do not understand. Speed okay? Speed not okay? So my way of feedback is this. Please do let me that if the speed is okay or not. Right? So the picture which you saw was a trabeculation. Now irritative symptoms. That means I'm going to talk about the irritative symptoms also. Irritative symptoms, one of the causes you have seen is bladder outlet obstruction. But it is not the only cause. There are 5 causes of irritative symptoms. Number 1 are neurogenic causes. Neurogenic causes can be diabetic neuropathy, Parkinson's disease, multiple sclerosis, stroke, tuberculosis can lead to irritative symptoms. Bladder outlet obstruction can lead to irritative symptoms. Why? Because they have detrusor hypertrophy. Number 4 is a UTI. In this class, how many of you had UTI? You can see you will have the urge to go to pass urine every 15-20 minutes. So that is irritative symptom. And last, very important, I have to go out of the way because I am not transparent, is a CIS bladder, which means carcinoma in situ of the urinary bladder. So carcinoma in situ urinary bladder, 5 Bailey's causes which causes irritative symptoms besides bladder outlet obstruction. Right? So remember the 5 causes. I think adequate time for the first comers to also understand, right, that there are, apart from bladder outlet obstruction and the mechanism I have told, there are 5 causes of irritative symptoms. Let us see the symptoms once again for the revision purpose. Obstructive symptoms are hesitancy. Hesitancy is failure to start, voiding. Right? Intermittent stream. Intermittent stream means stream comes, then stops, then stream comes, then stops. Then decreased flow, then retention of urine. These are the obstructive symptoms. A question definitely is destined to be asked, in which they will ask you that this is a symptom of what type, obstructive or irritative. Irritative symptoms. Bladder contraction taking place will lead to frequency. In the morning, if the bladder contraction occurs, it will lead to a sudden urge to pass urine. At night, if you are sleeping, you will wake up from your sleep to pass urine. And in either of the circumstances, if you are unable to hold the urine in the morning, it will be known as an urge incontinence. And at night, it will be known as a nocturnal incontinence. Right? So newcomers, I hope you have written this down. 4 symptoms which are obstructive and 5 symptoms which are irritative. Irritative symptoms are going to persist even after treatment. And obstructive symptoms usually go away. Right? So done and understood would be a better term, that you have done also writing and you have understood also. right? Beautiful picture from Bailey again. Cystoscopic view. Somebody was asking what is the use of a cystoscope. This is the use of a cystoscope. You can diagnose many conditions. What is this? Cystoscopy in a 55-year-old lady. Answer the following questions. So first of all, you have to identify what is this. So question is, what should be the next step? Question number 2 is, what investigation should have been done before cystoscopy in this patient? Right? Please tell me. Leukoplakia. Please. Leukoplakia. Shreya. Leukoplakia, no. See, this is papillary growth. Papillary growth means anything in medicine which means papillary. Means finger-like projections. This is the trigone. This is the trigone. Somewhere here will be the ureteric opening. This is the best place where you can see a carcinoma bladder. This is the carcinoma bladder. This is the carcinoma bladder. So carcinoma bladder is a big chapter, but we can't do the whole. But we must know how to manage questions in which the classical symptom of a carcinoma bladder is going to be a painless hematuria. Classical sign and symptom will be a painless hematuria. And when a patient comes with a painless hematuria, the next logical investigation which you should do is a urine for cytology, which is an older test. But in the urine, you can do something better also. And that better thing can be a NMP22. NMP is a nuclear matrix protein. The regular class people have seen that kit which is available. You can use it to diagnose, in some cases, carcinoma. But if you want to go for imaging, the first initial imaging will be an ultrasound. And then comes the next MCQ, that what will be the investigation of choice for a carcinoma bladder if ultrasound shows features of a carcinoma. Very nice. Many people have said the MCM also. I am not going. So what is the investigation of choice in carcinoma bladder? So please remember, the investigation of choice will not be a CT scan. Might as well write a negative notes, cut CT next to it so that you do not revise CT scan. You do an MRI to look for muscle invasion of the bladder. If it is a patient who has on an MRI a carcinoma of the bladder, the patient has to go for a TURBT. TURBT stands for transurethral resection of bladder tumor. All of you who are asking me to go fast, please do remember that you may be the ones who have already attended, and please also remember that even if I go fast, you do not have apparently a wife at home who's waiting for you. So there is no point of going fast, because whatever speed I'm going, it will finish in an hour from when I started, not from now, right? So TURBT stands for transurethral resection of bladder tumor. It has to be done, and histology will show whether it is TA or T1. TA and T1 means non-muscle invasive. Non-muscle invasive bladder tumors, the next option should be an intravesical BCG. BCG, remember, it is the same medicine which is the vaccine of tuberculosis, or mitomycin C. But question is, if it is muscle invasive, which is T2, that is muscle invasive, then you have to go for a radical cystectomy, right? So radical cystectomy, I have to get out of the way, or I'll write here radical cystectomy. And after radical cystectomy, you have to give a MVAC regime. Let me write it at the side. I cannot move this slide. MVAC regime is the chemotherapy. MVAC, where everybody must know, my regular students know that M stands for methotrexate. You have to tell me what is V. A stands for adriamycin, and C stands for cisplatin. V is the question. And please remember MVAC. V stands for vinblastine, and not vincristine. Right? So like Raj Lakshmi Singh and so many others who are going to mark vincristine in your exam, please put a cross so that you know that it's a wrong answer. MVAC, V stands for vinblastine and not vincristine. I hope everyone has written this. This flowchart is important. This is the best way I could summarize a CA bladder in one slide. Right? C stands for cisplatinum. Quickly identify this instrument. The company name is also written over here, but this instrument is vital for most of our surgery and medicine practices. This instrument is very, very important. What instrument is this? This instrument is very, very high chance of being asked because this instrument in Bailey has been given in at least 5 different pages and 5 different chapters. Please don't call it a true cut. This is a biopsy gun. This is a biopsy gun. Let us quickly see a biopsy gun. Right? And let us see how this biopsy gun operates. Please have a look so that you don't have to use memory to remember. You can see this video and you can remember. See, there are 2 knobs to push. And there is a hollow inside this needle where the tissue gets collected. And you have to, first knob is to press this. And the second knob, again the person is going to press. And both the knobs will go inside. Here it goes. Second knob also inside. I hope everyone can see this video. Right? True cuts are manual. This is not a true cut. True cut you have to do like this, manual. This is with the press of a button. See the pink button? When you press the pink button, it releases and a tissue will get trapped inside the hollow of this needle. This is a biopsy gun. True cut also works in the same principle, but it has a handle which you have to manually do. Right? So prostate biopsy, very important. Route is transrectal. Always remember, since it is transrectal, please remember always antibiotic has to be given. And very important question, it has to be truss guided. This is the only use of truss. If you need a suspicious, you have to take biopsy truss guided. And you have to remember how many cores. How many cores? How many biopsies do you require in a prostate? And all my students would require it. V for vinblastine, not vincristine. I do not know what V is. Mahipal is talking about. How many cores? So my regular students will revise with me. You need 12 ones, 12 cores, right? And please remember the new method of biopsy which can be taken, that is the transperineal route. For all of you DVT students, this will not be the answer because it is another 4 years for the new Bailey to come. And maybe after 4 years, the route of choice will change to transperineal. Today's route is transrectal. But you must be aware. T2. Okay, 12. Okay, not 12s. Very good. Right? So I hope everyone has written this also. I'm just turning the page. Just trying to turn the page so that the first comers can also write. Right? Something about Gleason score. Gleason score is 2 different carcinoma areas graded by 2 different pathologists, giving a score of 3 to 5 and 3 to 5, and when they add them, the Gleason score will become 6 to 10. Question is why you need a Gleason score. In no other malignancy you have a provision of 2 pathologists scoring 2 different areas and adding it. Why in prostate? So please remember that it is important because of prostate cancer being heterogeneous. There is heterogeneity. Instrument name is biopsy gun, not true cut. It's a biopsy gun. Right? Samia, it's going great for me also. Nothing better than start my day in the hospital and end up with so many youngsters. And one of the motives to probably have surgeons who are going to work with me in a medical college in Delhi. Right? So heterogeneity. Prostate cancers are heterogeneous. Now this comes the one very probable question. This is a X-ray from your belly which shows a radio opaque shadow in the area of the left renal kidney, and somebody may ask you which new score. Gleason score is not a new score. Please remember that this question can be asked, that is 25-year-old with a left flank pain, what is the possible diagnosis? The first thing one must say is that do not commit yourself to renal calculi on an X-ray. It cannot be renal calculi. Right? Because a radio opaque shadow here, I have already told, Bailey only says that there can be 7 possibilities. Number 1, it can be a calcified mesenteric lymph node. It can be a gallstone. Just now you had a hepatobiliary class. 10% gallstones are radio opaque. They can mimic renal stones. It can be a seed of a fruit, some foreign body in the intestine. It can be a calcification of the vein wall, phlebolith. It can be an ossified tip of the 12th rib. It can be a tuberculous calcified lesion of the kidney, and it can be an calcified adrenal glands. Again, quickly, the ones who are right. So please understand, there are 7 differential diagnoses of a radio opaque shadow which looks like a renal stone. So please do not say immediately that it is a renal stone. You need more investigations to confirm that it's a renal stone. Right? In CA bladder, somebody was just confused between CT scan and MRI. Please do cut CT scan and please tick MRI. Cutting a CT scan will help you remember that CT scan by mistake should not be asked. Right? So these are the differential diagnosis of a renal stone. Now some scenarios. Ones who have done my class before, let me see whether you can answer this question. 2 centimeter lower calyx stone. Answer: treatment should be PCNL, RIRS or ESWL. Those students who are attending it for the first time, RIRS stands for retrograde intrarenal surgery. So 2 centimeter lower calyx, PCNL, RIRS or ESWL. Unfortunately, I would love to tell about each of these. I'm going to show you few of these, but I can't do in great detail because it's again a revision class. So many of my students, I see that they're marking it as a PCNL. The size here is very important. It is 2 centimeters. So let us know why the answer should be RIRS. You'll again come to know why it is RIRS. Please remember, RIRS will always be the answer if in a question it is written as an ectopic kidney with stone, if it is given as a horseshoe kidney with a stone, if it is given as an obese patient, and if it is mentioned in the question that there is a hemophiliac patient with a renal stone. In all of these scenarios, RIRS will be the answer provided the stone is less than 2 centimeters. Right? So the X-ray you saw, it can be renal stones, plus it can be the 7 differential diagnoses which are taken directly from your Bailey book. 7 differential diagnoses. Right? So please remember, the moment it is lower, ESWL will be out, because ESWL contraindication is lower calyx. Because ESWL is going to make the stone into a powder, but this powder will not come out because it is lower calyx. Right? So that is what I am discussing. Akshara, the last question diagnosis, I told you that you have to have other pointers. It can be a renal stone, it can be other things as well. So that is what I am telling you, that don't commit it's a renal stone. See the question in more details. Now another scenario for all of you. 5 centimeters lower calyx stone, PCNL, RIRS or ESWL. The moment you find in a question lower calyx, ESWL is cut. The moment you see more than 2 centimeters in a question, RIRS will also get cut. So the answer will be PCNL. Right? So all those who are new, I'm just telling you the guidelines. Please, in the later part, I'm going to show you the page from Bailey, which will make you very easily remember what to do. I am just telling you for now, in 2 months, in a stone question you should do. The moment it is lower, please cut ESWL. The moment it is less than 2 centimeters, you can go for RIRS. If it is more than 2 centimeters, you should go for PCNL. Right? 3 centimeters upper calyx. 3 centimeter upper calyx. It is not a lower calyx anymore. Plus it is more than 2 centimeters. So please remember the answer will be ESWL oblique. Even PCNL is correct answer. Right? So if you ask, somebody asks what is the treatment of choice between ESWL and PCNL, you can go for PCNL. But ESWL will work even for an upper and a middle calyx. Right? So let us quickly see this diagram. Quickly see your pages. I see your pages and then quickly tell me first question. What is the diagnosis which you see? What you see here is a picture like this on the left kidney. It is different from the previous question. In the previous question, it was a round radio opaque shadow. But you can see this. This is the shape of the pelvis and calyx. So perfect. Many people have answered it. This is a staghorn calculus. But the question is, why is it not an IVP? So there are many students who keep asking me, right? So why is it not an IVP? It is not an IVP because you cannot see the parenchyma of the kidney. You do not see the ureters. You do not see the opposite kidney. So this must be a X-ray KUB. Right? So this must be an X-ray KUB in which you are seeing a staghorn calculus which is occupying probably the entire left pelvis and the calyces. This is a CT scan. Please see. This is a CT scan of the same patient. So the question was what should be done next. So in a kidney, if we revise again, if somebody asks about kidney investigation, then kidney investigation has to incorporate 2 things in a kidney. Without that, treatment is not possible. There should be anatomy and there should be function. Right? Aishwarya, please wait. I'll be telling you why not PCNL, why not other things. So in a kidney, you saw the X-ray, you need a functional study. Giving a dye and a CT scan is a functional study. Please see, you can see dye in one of the kidneys. You can see the staghorn calculus. So this is the calculus. And you can see dye. This is dye. Right? Treatment of choice of a staghorn calculus is PCNL. Remember this. No time to go into any logic. Staghorn calculus treatment of choice will be PCNL. Yes, MAG, DTPA, LLEC, these are all functional studies, correct. Those who are telling are correct. Now quickly let us see a video of a PCNL. So the patient will be prone in a PCNL. The first thing in a PCNL is to have an approach. See, the surgeon is going to have an X-ray guidance. The instrument which you see is a C-arm known as a fluoroscopy. The surgeon is going to put a needle through the skin into the pelvis or the calyx through the back skin. So percutaneous nephrolithotripsy or lithotomy. Right? Let me fast forward you and please see that the puncture has been done. See, the puncture has been done. The surgeon is now going to insert a nephroscope. See, this is the video where you can see the stone. This is the view of the scope. On your left lower corner, you can see the view of the nephroscope which has entered the pelvis. Through a small incision in the back, you can see the brown stone in front of you. The surgeon is going to break it, and then piece by piece is going to take this out. This is how PCNL is done. It's a keyhole surgery. So the next investigation, Shamul has asked, would be a functional study. Most cases it will be in older times it used to be an IVP, but in today's time it can be a CCT. Yep, it will be needed in NEET so that you remember how is PCNL, what is the position of the patient. It is prone position, and this is a small keyhole incision. These are all tricks to remember. A quick about RIRS, retrograde intrarenal surgery, which requires a flexible ureteroscope. See, a flexible ureteroscope goes in, holds the stone, breaks the stone into smaller pieces. Right? You break the stone, and incision? No incision. This instrument has reached the pelvis through the urethra penis or the urethra bladder, ureter, and reached the pelvis or the calyx. See, very nicely. This is RIRS without an incision. Right? So this is the query. I am going to give you some time. Please write it down. This is Bailey's paragraph. Please see retrograde intrarenal surgery indications. Renal stones less than 2 centimeters. If you ask me to zoom, I'll zoom it. Yes. So Dr. SR has said it correctly. This was also your instrument question, and that is Dormia basket. Lower pole calculi, obese patient, patients with horseshoe kidney, pelvic kidney, bleeding patients. What you are writing and witnessing are the Bailey's indications for RIR. So after this, please do not ask me why above 2 centimeters something else, why less than 2 centimeters something else. These are the written rules given in most of the books. Especially for you, it should concern your Bailey love. So see, please do not forget the 5 indications of RIRS today. Please tell me you have done and understood. HSK, Sakshi stands for horseshoe kidney, fused kidney. So many people have said that they have done and understood. Let us quickly see the indications for PCNL. So quickly see the PCNL. All stones more than 2 centimeters, lower pole renal stones, failed shockwave lithotripsy, SWL. You are going to ask me what is SWL? SWL is shockwave lithotripsy or ESWL. RIRS, please don't ask me the page number because this is something which you are going to use your pen and your hands to write it down. I have not given it to you. Right? You have to write it down. Bleeding diastasis Siddharth means hemophilia. That means patient who have bleeding disorders. And please note all Staghorn calculus, they ideally have a PCNL. That is why the treatment of choice for Staghorn calculus will be PCNL. Please tell me you have done it. Sorry, Aditya. Right? So going forward, quickly, this is a micturating cystourethrogram. In short, this is known as MCU. In a 30-year-old man who is having sterile pyuria. Sterile pyuria is a big hint. What is the diagnosis and the management? This is an MCU, micturating cystourethrogram in a 30-year-old man with sterile pyuria. My students know the 5 causes of sterile pyuria, in which the 2 main causes which I will tell today is tuberculosis and carcinoma in situ bladder. Right? So please remember, this is an MCU film which is showing a small capacity bladder. Right? Let me move away. If you can see, this is a small capacity bladder, and this is known as a what kind of a bladder? Everyone knows in tuberculosis it is known as a, yes, you know the answer, thimble bladder. Not thimble, it is thimble bladder. Plus, please note that you can see the right ureter, reflux into the right ureter. You can also see the right pelvis. And please do not miss fecalith. There is lot of stools here. These are all fecal matter. So these are the questions how you have to train your eyes. This is an MCU which is showing a small bladder, and this patient with a small bladder is not going to have a good social life. No girlfriends, no boyfriends, no social life, no neet, no DVT. For DVT you need to sit from 9 to 9 in the night. So in this patient he needs to go to the toilet or he'll be incontinent. Right? So please remember something about augmentation. What is the principle of augmentation? No, Boris flap is for ureters. Augmentation principle is to convert this small bladder into a big bladder so that he can retain the urine for 4-5 hours so that his social life improves. And when you increase the capacity, the pressure inside the bladder will become low. This is what you want to achieve. Right? How to differentiate ureterocele, I will not tell now. Just go through the parts which I am telling you. When you do augmentation in a patient, the patient has to pay a small price for augmentation, because in augmentation his contraction capability of the bladder will reduce. Therefore, he is going to have high residual urine. For this patient has to do self-catheterization. He has to put a catheter his own way inside to evacuate the urine out. And a question is likely to be asked. And that question is, what is the surgery name where you use appendix as an artificial conduit for self-catheterization? For self-catheterization, you can use your urethra also. But if you use your urethra all your life, you are going to have stricture. So, very nice. Some of you have already attended. CISC stands for Clean Intermittent Self-Catheterization. These notes are not there. You have to write it down. There is space for you to write it down. Please remember the name of the surgery in which you use an appendix to create an artificial channel for which the patient can have an appendix on the abdominal wall through which he can put a pipe into the bladder and empty his bladder. CISC stands for Clean Intermittent Self-Catheterization. We go on to the complications, very important. Without knowing the complication of augmentation, I don't think you are eligible to appear for an exam of urology, because in general surgery also people ask the metabolic complications of augmentation. So what kind of complication metabolic is going to be seen? Hypochloremia, hyperchloremia, metabolic acidosis or metabolic alkalosis. Surgery name was Metrophenol. Quickly, Metrophenol. ना जी, मनप्रीत जी, ये नीट एसएस की नहीं है. दिस इज फॉर योर normal PG question, and if you answer all of these, you will have an automatic admission into SS as well. You can choose your 6-year integrated courses. Right? So please remember the metabolic complication: hyperchloremia, metabolic acidosis. Hyperchloremia means increased chlorides in the blood. Metabolic acidosis means pH less than 7.35. And anyone who is going to have this metabolic acidosis is going to have bone problems. Right? So bone growth will be stopped if you have acidosis in the body. There are going to be some bowel complications. Let us quickly see the bowel complications. If you are going to remove the ileum and the cecum to put it into bladder to increase the capacity, then diarrhea can occur. Patient can have anemia. Very important question, because you're removing the terminal ileum. Patient can have a B12 anemia. Patient can have gallstone. You just did the class on hepatobiliary revision, right? Yes, Gohel Harsh. Potassium would increase in a metabolic acidosis. That was part of your general surgery. In acidosis, there will be hyperkalemia also, right? So gallstones can also occur because you're removing the ileum for using it in bladder. You can have stone formation in the new bladder. You can have infections in this augmented bladder. And very, very important question is, what kind of cancer will arise in a bladder which is augmented, in which intestines have been put? So Tanya is I think the first one to answer very, very quickly. Tanya, thank you so much. The cancer will be adenocarcinoma. Adenocarcinoma is the cancer of the bladder when you are talking about an augmentation. Transitional cell cancer is the cancer which you just saw in the image. It is a papillary growth. That is a transitional cell cancer. Right? All of you who are new, I hope you had time to done and understood as well. You have written this down. You have written the key questions which are asked. Anemia, B12, gallstones, adenocarcinoma. Very, very important. What is the diagnosis? You are seeing, first of all, you have to tell me whether this is identify the investigation, right? Let me zoom it. You have to see a zoom image because this is again a Bailey image. I'm showing both the images. You see a CT, this one, cross section. You see another cross section here of the same patient. You see another sagittal coronal section, this one. And you see another section lower down, this one. The question is whether this is a NCCT, non-contrast CT, or a CCT. I don't have enough time, but in radiology also they have told you that this is the problem, this is the problem, this is the problem, this is the problem, this is the problem. Investigation of choice for urolithiasis is NCCT. There are no vessels, no kidney parenchyma, nothing seen. So no dye has been used. So this is a NCCT. And what do you see in this NCCT? You see bilateral renal stones. These are bilateral renal stones. You can see this one and this one. You can see bilateral ureteric stones. And you can also see a mid ureteric left-sided stone. Again, let me show you. This is a bilateral renal stone. This is a left mid ureteric stone. Same mid ureteric stone in another view. And this is urinary bladder. The black round thing is the urinary bladder. You have to identify this. No way. And just at the bladder, you are seeing two lower ureteric stones. So stones will appear on an NCCT like this. You have to identify this. And in these questions, please understand, the question can be asked in a bilateral stones, which side should be operated first, the better kidney or the worse kidney? Better kidney or the worse kidney? Kaushik Chaudhary, you have to say these are stones because these are white. Stones appear white on a NCCT. It has to be there in the workbook. It is there in the workbook. Right? So there are still many who still believe that it should be the worse kidney. Please remember, it has to be a better kidney first. Better kidney is always operated first, or the kidney which is causing the most symptom. So better kidney always operated first. Quickly identify this. This is the problem. This side is normal. The age group is a big hint. 65 years old. Diagnosis and the treatment. right? So this is a clear-cut, very distorted kidney. This is a renal cell carcinoma, usually occurs in more than 64 years. Risk factors, first time has been given in the 27th edition of Bailey. I have told my students, the ones who are new, please note, this is a very important question, cancer and risk factors. And that too, a new risk factor which has been added in a Bailey is an old male, obese, hypertensive and a smoker. Right? So 5 risk factors: old, male, obese, hypertensive and smoker. These are the 5 risk factors of RCC. And please remember, the commonest histological type is a clear cell. Famous syndrome with which it is associated. But Campbell is not used for your questions, sorry. Bailey is used for your. So I wish you come into urology. For that you have to take an MS surgery. Which is the syndrome? VHL, very good. Von Hippel-Lindau syndrome. Lung metastases are called as the cannonball lesions. You just have to revise with me which are the other cancers in the body whose lung lesions are known as cannonball lesions. Yes, I have told you, all germ cell tumors, seminomas, yolk sac tumors, teratomas, dysgerminomas, choriocarcinomas, all germ cell tumors are going to have cannonball lesions. Nephrectomy is the radical nephrectomy is the treatment of choice. And here are the questions which are likely to be asked again. Quickly help the newcomers to answer this. Which is the first structure in a radical nephrectomy to be identified? Please remember, the structures in a kidney are oriented like this: VAP, vein, artery, pelvis. Anterior-most is vein, then artery, then pelvis. Quickly tell me which one should be identified first. Right? So the first structure to be identified should be artery. Which structure should be ligated first? So first structure to be identified should be an artery. First structure to be ligated in a nephrectomy should be again artery. And the first structure to be cut will be a renal vein. Right? So all those who are attending for the first time, direct lines from Bailey, many times has been asked. Unfortunately, Campbell also, one of your Campbell fans has said, it is also given in Campbell and all other books. No confusion, no problem. First structure to identify is artery. First structure to ligate, not cut, is artery. And the first structure to cut will be a vein. Right? RCC is a radio and a chemo sensitive tumor. Right? True, false, partially true. So please do remember, this is a absolutely false question. This is the only cancer which is chemo and radio resistant. No effect on radio, no effect on chemotherapy. Quickly identify the investigation. What is this investigation? Again a picture from Bailey and Love. This is a picture from Bailey and Love. What is this investigation? Very nice. And Ravi is the first person to answer this, that this is a uroflowmetry. Let's quickly revise the normal flow rates. The normal flow rate is more than 15 ml per second. Decreased flow rate, quickly revise, is less than 10 ml per second. Between 10 to 15 is equivocal. Equivocal means you can't come to a conclusion, and the person has to pass a minimum of 200 ml of urine. Right? So if you want to get a uroflowmetry done for any of your family members also, he has to drink the lot of fluid and he has to pass a minimum of 200 ml of urine. Only then these values will be valid. More than 15 is normal. What about pressures? Normal pressure, you and me, at the time of voiding will be less than 60 centimeters of water. High pressure, which is bad for the kidneys, is more than 80 centimeters of water. And 60 to 80, equivocal. You can't come to any conclusion. And hence, if I ask you what is the definition of a bladder outlet obstruction, you know bladder outlet obstruction means high pressure, low flow rate. High pressure more than 80, flow rate is less than 10. Nephrectomy wala, I tell you Ashwini, first structure to identify is a artery. First structure to ligate is again an artery. First structure to cut is a renal vein. Equivocal means you can't come to any conclusion, right? Quickly diagnose this. This has been shown many times in your radiology class also. This is quite easy, and this is a typical flower vase appearance, right? Please remember it is fused at the lower end. Horseshoe kidneys are always ectopic. Very good. The location of the pelvis will be L4 and L5, and in an asymptomatic patients we do not do treatment. Please remember, I feel the question will be asked on this. A horseshoe kidney, and options will be cutting the middle part, separating the kidney, doing this, doing that. No treatment for asymptomatic patients. So this is the picture of a horseshoe kidney. Let us quickly go into this. Another picture which is commonly shown in your radiology. What is there? This side is normal, no hydronephrosis. This side is normal ureter. But look at this ureter over here. Look at this pelvis. This is hydronephrosis. And what is happening? The ureter is coming like this, and it is tapering over here. Very, very nice. And I think Mohit is the first person to answer this. Very good. This is known as the retrocaval ureter, in which you are seeing a reverse J sign. Please do remember, this is again a very big hint in your questions. This is only going to happen on the right side because inferior vena cava is present only on the right side. In this, the ureter is being obstructed by IVC. Right? And please also remember, in the class I never did for all of you the treatment. Bailey gives the treatment for retrocaval ureter is a pyeloplasty. Symptomatic Abid, ABCD, the symptomatic horseshoe kidneys will be operated as per the symptom cause. Stones, you remove stones. Pelvic ureteric junction obstruction, you will do surgery for pelvic ureteric junction obstruction. But asymptomatic patients, no treatment. Pyeloplasty is the treatment for retrocaval ureter. Last slide. Last slide. This is the last slide. Quickly. 5 seconds. 1, 2, 3, 4, and a 5. Right? This I have not done even in my regular classes. This is something which you must know. You should be able to identify this condition. So quickly write this. For this, everyone has to write now. This is a condition in which you are seeing a ectopy vesicae, which is in complete totality known as an extrophy epispadias complex. So this revision should also incorporate those parts which I have not done with you. So what are the components? Lower abdominal defect. Anterior wall of the bladder is open. Urine is coming out. Pelvis bone is opened like this. Pelvis bone opened like this. And patient is incontinent. And do remember, the treatment for this going to be staged repair. You do it repair in stages. Right? So please, for a March exam, just see this picture and make an impression of this picture. This is a extrophy epispadias complex. That means bladder is also open and penis also is abnormal. Please see what is abnormal in penis. Please tell me, most of you have done and understood both. And the next slide we are going to do, what timings are there we have to observe for treatment. Right? So let us see the timings of the surgery. The first, in the neonatal period, you must close the bladder. The bladder needs to be closed in the neonatal period. Epispadias has to be repaired same like an hypospadias at 6 months to 1 year. And these patients will not have control on the bladder. It cannot stop the urine. So that surgery for bladder neck repair has to be done between 5 to 7 years. So this, the whole of you who are seeing this have to write it down, because this has not been taught by me. This is something in addition to what I have already done in urology, something extra. This image is again from Bailey and Love. What sign, Moria, are you talking about? It was known as the reverse J sign for retrocaval ureter. Right? So timings, 3 stages: bladder closed, epispadias repaired, and bladder neck repair is 5 to 7 years. Quickly identify what this picture is showing. If I zoom it out, if we zoom in, then it is pressure detrusor, pressure vesicle, pressure abdomen. Right, here comes the volumes, pressures. What is this investigation? So please remember, this investigation again taken from Bailey and Love. If somebody gives you this investigation, this is a urodynamic study, also known as a pressure flow study. And please remember, it is not only the investigation of choice, but this is the investigation of choice for management of neurogenic bladder. So for all neurogenic bladder, a pressure flow study is equal to your urodynamic scan. Please remember, again image is from Bailey. All images of Bailey's are important questions. Urodynamic scan, also known as a pressure flow study. A quick view, a formula which you must all just memorize: pressure of the detrusor is equal to pressure inside the bladder minus the pressure of the abdomen. That means the rectal pressure. Again, the formula is given in Bailey. Pressure of the detrusor cannot be measured directly. It is indirectly measured as the pressure inside the bladder minus the pressure of the rectum, which is the abdominal pressure. Any graph like this which you see, P det, P ves, P abdomen written, is a urodynamic study graph. A quick video of how this is performed. You can see a bladder catheter. You can see the machine which is measuring this. This is just a way, my way to make you remember a urodynamic scan, which is done very commonly, and it is being used for. So quickly identify this instrument, this prosthesis. I should rather call it a prosthesis. So many of you may not be able to identify this. Again, image from Bailey. This is an artificial urethral sphincter. This part is put around urethra, and this is the cuff, and this will be used in all patients who have an injury at the time of TURP, because you did resection at the virumontanum. Remember the first part of the class. If you injure the virumontanum, external sphincter is going to be injured, and this will lead to incontinence, and that can be treated only by this. Very famous question: 60-year-old man with a narrow stream, that means some bladder outlet obstruction with a back pain. What is the diagnosis and what should be the treatment? So this X-ray has been given. This X-ray is very typical. You see how the whole pelvis has become white with few black areas. Something wrong. This is not normal. So any patient with a bladder outlet obstruction with a bone pain, pelvis pain is equal to carcinoma prostate. And prostate is the most common source of bone metastasis and not breast. Please remember, many of your friends will mark it as breast. The most common cancer to have bone metastasis is prostate. And please, before the exam, please remember that the most common metastasis in prostate is osteoblastic. Please also ensure that you are able to see the picture and you can. So most commonly it is osteoblastic. Osteoblastic means bone forming metastasis. Everything looks white. Lytic lesions are less. In breast also both can happen, but lytic are more common than blastic lesions. Right? Done and understood? Absolutely here. So if your transabdominal ultrasound shows a suspicious lesion in the prostate, you should do a truss guided biopsy. Right? This is the line from Bailey. Please see, prostate is the most common site of origin for skeletal metastasis, followed in turn by breast. So prostate is the most common source of bone metastasis. Quickly identify this. This is again an MCU, micturating cystoarthrogram. You can see the bladder here, and this is the posterior urethra. So what is this sign? This is the urethra. So confusion, many students will ask why this is not an RGU, why this is an MCU. So quick way, please remember, RGU has more of urethra and less of bladder, and MCU has both bladder and urethra. So this is a keyhole sign like this. This is the keyhole sign, right? So please remember, this is a micturating cystoarthrogram which is showing a keyhole sign. I have explained why it is not an RGU. It is a diagnosis of a posterior urethral valve, and the treatment of choice is a cystoscopic fulguration of the valves. Right? So Pradeep Raj, I'm really sorry, CA prostate, I would love to talk about. Let us first finish, and then if time permits, then I'll discuss. Let us quickly see something, some orientation. Somebody asked what is the role of cystoscopy. Please see, it is all labeled. Please keep on seeing. This is the anterior urethra. Please see virumontanum. This is the male urethra. Posterior urethral valves can only be seen in a male urethra. Please see and see how valves are. Posterior urethral valves. See, they are like curtains. See, these are the posterior urethral valves. You can see they are originating distal to the virumontanum. And when we go inside the bladder, you can see this is trabeculated bladder. This is irregular surface because see, the bladder has irregular surface. You can see the ureteric opening here. This is the right ureteric opening. This is the left ureteric opening. Yes, correct. 70 years, whatever people are saying, that is correct. I have given you the last slide for that during my regular classes. Please see, this is cystoscopic fulguration of valves. Nishant, I'll tell you the CA prostate treatment in a while. Just wait. So this instrument is like a resectoscope where we are going to cut on the valves at 3 places. 12 o'clock, see, the tip is now going to be turned to 12 o'clock. Let us see, this is burning the valves at 12 o'clock. You can very clearly see how the valves are burnt. These valves were causing the problem, obstruction. See, this has been cut. Next, 5 o'clock. See, this is 5 o'clock. And then 7 o'clock. This is 7 o'clock. So 12, 5 and 7. Quick diagnosis. Diagnosis. Ulta of epispadias. This is a very common one. This is hypospadias. Appropriate age to operate. I have not told my regular class also. The appropriate time to start operating on hypospadias is after 6 months of age, and hypospadia surgery should be completed before 18 months of age. Right? All surgeries of hypospadia should be completed before 18 months. Question is why? Why is because of two reasons. Number one, after 18 years, psychosexual development starts. The child starts understanding what is male, what is female. And number two, there is a physiological amnesia before 18 months of age. Even you will not remember your life before 18 months of age. So best for the surgeon, the patient does not remember who did the surgery, who took the money. Right? So please remember 18 months is a landmark year. Quickly write the defects in an hypospadias. In a hypospadias, the prepuce is hooded. Hooded means if this is the glans, the prepuce is only present on the dorsal side, like a hood of a snake. Number two, the meatus is proximal. Number three, the urethra is also defective. The penis will be curved like this. That is known as a chordae. The glans, as you can see here, this glans is open. This is also defective. And in some cases, the scrotum may be bifid. So 6. Ventral chordae. Epispadias will have dorsal chordae. Hypospadias will have ventral chordae. Yep, Bosnia classification, Dr. SR, Dr. Senior Resident has Bosnia classification. Bosnia classification is renal cyst. CT classification, whether malignant or benign. Fourth point, abnormal ventral curvature. Abnormal ventral curvature, right? So, chordae and a bifid scrotum, right? This is the classification given in Bailey depending upon where the meatus is. Mark what? In the photo. So I do not have a side view. In a side view, the penis will be bent like this. This is chordae. Right? This is a classification of hypospadias depending upon where the opening is opening. Diagnosis. I wanted to show you this picture. This is the opposite of hypospadias. This is isolated epispadias. The previous picture which you saw was an extrophy epispadias. And if I ask 100 students which is more common, extrophy epispadias or only epispadias, 99 students will say that it is epispadias more common than the previous one, because that is a lot of defect. But please understand that isolated epispadias is less common. More common is a extrophy epispadias complex together. Right? So this is the chordae is going to be dorsal. The meatus is going to open dorsally, lower down. So this is epispadias. This is scrotum of this patient. This is dorsum. So please make your orientations correct. And let's go quickly to the very famous question, and that is, this is very highly likely because many of you in your clinical practice is going to end up result in making the penis like this. Please remember, this is paraphimosis. This happens when you retract the prepuce and do not bring it back. Please also remember the treatment. This is not phimosis. Anushka, this is not phimosis. This is not phimosis. This is paraphimosis. This is the glans and the prepuce has gone back. So please remember, retract it back is one of the treatment. If retraction is not possible, you may need to do circumcision. This is paraphimosis. Please learn to identify paraphimosis. Going on to the next one, everybody knows this. I won't spend time in this. The diagnosis is a drooping lily sign. And question is again very important. Please remember, if asymptomatic, then you do not treat. By the ways, which pole is usually the problem? Which pole is usually the problem? The upper pole or the lower pole? Which is going to be the problematic in a duplication? So please remember, the upper pole is the problem 99% of the times. You can see the middle calyx, you can see the lower calyx. This is the pelvis. The upper calyx is the problem 99% of the times. So in these cases, you may have to do a upper pole partial nephrectomy. Right? Another question on, you have to learn, train your eyes to see this. This is one ureter and one pelvis. The ureter coming like this, opening here. The other ureter is going like this. Both the ureters are meeting here and they are inserting into the bladder. Right? So please remember, this is a left incomplete duplication. And the treatment in an asymptomatic patients like a horseshoe kidney, you don't treat them. You treat them only when there is a symptomatic patient. Retroperitoneal fibrosis, no, Dr. Ria, this is not a retroperitoneal fibrosis. This is a duplication. Right? Now quickly let us see duplication varieties. There are two types of duplication. In one, the two ureters will fuse to each other like you saw in this picture. If they fuse to each other, it will be known as an incomplete duplication. But if the two ureters do not fuse to each other and they remain separated, then it will be called as a complete duplication. Please remember, out of the two, incomplete duplication is more common. So please everyone, duplication are of two types. Ureters fuse at the lower end is the most common type. It is known as the incomplete duplication. And ureters which remain separated from kidney to the bladder, they are known as a complete duplication. They are less common. Absolutely correct, Siddharth. Wiegand-Mayer law. Nephrectomy wala sequence. First to identify in a RCC is renal artery. First to ligate is a renal artery. First to cut is a renal vein. Normally there is no duplication. Right? This is Wiegand-Mayer law. Wiegand-Mayer law says that from the kidney, if there are double ureters, then the upper ureter is the one which is going to insert ectopically into the bladder. And the lower ureter is going to normally insert. Right? So Wiegand-Mayer law. For the newcomers, please remember, the upper ureter will insert ectopic. Upper moiety is at the more inferior and medial position. And the lower moiety is going to be at the normal position. This is Wiegand-Mayer law. In a Wiegand-Mayer law, upper ureter from the upper pole is going to be ectopic. And lower ureter from the lower pole is going to open in the normal position. Now this is important. What is this sign? Very difficult. Even my regular students won't be able to identify this. What is this sign? In the scrotum, left side. Who can identify this sign? A blue spot. Right? I'm going to. So very nice. Somebody said torsion, and I think Bhavna has said it correctly. This is known as the blue dot sign. This is not a torsion of the testis. This is a torsion of the appendicular appendage in the testis. In the testis, there is a small protrusion like this in a normal testis, which is known as the appendix. And this is a torsion only of the appendix, and this is known as the blue dot sign. And please remember, again the picture is from Bailey. Please remember the treatment. In a blue dot sign, torsion of the appendix of the testis, you do not need to do anything except for analgesics. You don't need to do scrotal exploration. But question is, if you cannot differentiate, if you are having problem differentiating, then you should go for a scrotal exploration. But if you are sure that this is an appendix of the testis torsion, then you don't need any treatment other than analgesics. Exactly not. So Shravan has said Mullerian remnant, exactly not. Right? Famous procedure known as ureterosigmoidostomy. This is done for radical cystectomy, some of the patients where the ureters are opening into the sigmoid colon. Very famous question asked, what is the complication? You have already done hyper or hypochloremia, metabolic alkalosis or acidosis. Yes, blue dot sign can be seen on a Doppler. And blue dot sign is a clinical sign. The skin of a fair-skinned scrotum will see as a blue spot. What has happened? Ehtesham has written metabolic alkalosis. Please know, whenever urine is collecting in the bowel, it will always be metabolic acidosis. Why? Because urine has ammonium. So whenever ammonium is getting collected in the intestine, this ammonium should have been excreted out of this body. So this ammonium is absorbed by the sigmoid, by the intestine, goes into the portal circulation, into the liver. The liver will break the ammonium into H plus and ammonia. Ammonia will get detoxified by the liver. You have had the hepatobiliary class just now. It will get detoxified. Rather, I should write here detoxed. And the H plus is going to cause metabolic acidosis. Right? So this is the answer to the question, that ammonium which is present in the urine is going to cause all of these complications. And ammonium also blocks the chloride channels of the intestine, leading to hyperchloremia. So augmentation, ureterosigmoidostomy, in any condition where urine is collecting in the bowel, hyperchloremic metabolic acidosis is going to be the complication. Yes, even if you create a rectal pouch, Amrut, you will have this complication. Rectal pouch, if you are having ureters opening into the rectal pouch, you will have the same complication. Right? Please tell me you have done and understood. The regular students have already written that in their notes. The new ones, I hope you have quickly written this. Tuba has said done and understood 2 times. Bladder rupture, if I get time. What is the investigation of choice? What do you see? What is the investigation of choice? So pictures like this, apply, and you have to answer. What is the investigation of choice? How do you manage such cases? Right? So let us quickly do how do you manage a scrotal lump. You have a testicular mass. On clinical examination, you have a suspicion. The first thing you should do is an ultrasound scrotum. I hope everyone has written this. Testicular mass suspicious on a clinical examination, you go for an ultrasound scrotum. Here you should write big. FNAC is contraindicated in a scrotal lump. If you find that it's a malignancy, if you think it's a malignancy, then you should send the tumor markers, which stands for alpha fetoloprotein and beta HCG, and plan a high inguinal incision and the delivery of the testis from the lower abdomen. That means you are going to give an incision. This is the scrotum. You are going to give an inguinal incision to deliver the testis from the inguinal region. You don't operate from the scrotal root because malignancy gets disseminated. Then if you find, looking at the testis intraoperatively, that it looks malignancy, it is suspicious, then you do a biopsy. If biopsy confirms it to be a carcinoma testis, seminoma or germ cell tumor, then you do a staging investigation, which is a CCT abdomen. It will stage the cancer into two types. Please remember, this is something very new for all of you. In older times, seminomas were known to be classically a radiosensitive tumor, but now for seminomas we do not give radiation. For stage 1 and non-seminomatous stage 1, we only do observation, surveillance. And for all other stages, we give a BEP regime. So I'm going zooming. So testicular mass on clinical examination, we go for an ultrasound of scrotum. If you are suspicious, you send a tumor marker. If again you are very strongly suspicious, you give a lower abdominal inguinal incision, deliver the testis out. If you feel it's a malignancy, you do orchidectomy, wait for the biopsy. Biopsy comes out at malignancy. You will do a CT to look for nodes above the diaphragm, below the diaphragm. If it is stage 1, limited only to the scrotum, then you should do a only CT and tumor marker surveillance. Other than stage 1, whether it is seminomatous or non-seminomatous, the treatment will remain the same, and that is BEP regime. BEP regime stands for bleomycin, etoposide, and P is the main question. P is what? Prednisolone, paclitaxel, what is P stands for? So P stands for cisplatin. So all of you who says this is a right. So for the half of my class, good luck from the lady, and for the rest half of the class, good luck from the